This morning, I want us to finish up this chapter, um, starting with the cardiac cycle. You know, we've just talked about the path of blood through the heart, so you can name all the blood flow and name all the chambers, name all the valves. Well, the event of that is called a cardiac cycle, the movement through the atria, down to the ventricles, and then out of the heart. You have however many heartbeats you have in a minute, that's how many cardiac cycles you have in a minute. Okay? Um, so, when that occurs, you have atrial contraction, atrial relaxation, ventricular contraction, ventricular relaxation. Okay? And the cardiac name for a chamber contraction is called systole. It's not systole, it's systole. And then the cardiac name for a chamber relaxation is diastole. So you have the blood, let's say right here, let's say blood's flowing into the atria on each side. As the atria are filling, they are in diastole. That's the relaxation or the filling of it. And then when they contract, that's atrial systole. Okay, as they contract, the ventricles start filling, and so that's ventricular diastole. And then when they contract to push that blood into the arteries that leave the heart, then that's ventricular systole. Okay, so systole is contraction, diastole is relaxation, regardless of which chamber you're talking about. Okay, all right, and so that event of the alternating contraction and relaxation of these chambers is referred to as a cardiac cycle. And this looks real wordy. It is real wordy, but you already know every bit of this, okay? Because I have gone through it a gazillion times in the last lecture, okay? And so during that time, pressures in these various chambers change. That makes sense, doesn't it? The pressure due to the presence of the blood there. Okay, so during atrial systole and ventricular diastole, so that occurs at the same time. That's when the ventricles are relaxed, and by relaxed, that means they start filling with blood, okay? And they're filling with blood. Some of that blood is just moving passively from the atria into the ventricles as they fill, but then the atria actually contract to push the remaining part of it into the ventricles. I've talked about that before, okay? But then as the ventricles then get filled up, then they start to contract, and that's going to cause the bicuspid and tricuspid valves to close. And so the only place the blood can flow is into either the pulmonary trunk or the aorta, depending on, where the blood is, in which chamber, okay? So please don't sit and just memorize these bullets. Just look at a picture of the heart and talk through the blood flow, because you already know this, okay? I promise you do. If you know the path of blood through the heart, you know this, okay? So you shouldn't have any problem on the questions, okay? All right. So when we talk about your heartbeat or your heart sounds, that lift up, lift up, lift up, lift up. Okay, what you're hearing is actually the action of the valves closing. That makes a resonating sound throughout the body wall, and that's picked up with the stethoscope. And so there's two sounds to your heartbeat. Lift up, lift up, lift up, like that. And the first sound is when the ventricles are undergoing systole. So what are they doing? Contracting. And so which valves, don't look up here, which valves close when the ventricles contract? Just visualize it. The valves up into the atria. The tri and bicuspid valves close when the ventricles contract, because that pressure pushes the flaps up, and the presence of the chordae tendineae prevents them from moving in the opposite direction, right? Okay. So the first sound is due to the closing of the AV valves. That's the tri and bicuspid. AV means atrioventricular. Okay. And then when the ventricles relax, blood is going to back up in the aorta and the pulmonary trunk. Okay, so if we look, let me show this on a picture here. Okay. So, um, here you see how the ventricles are contracting, they're in systole, and so that puts pressure on those flaps or cusp of the tri and bicuspid valve, so they're going to close. Um, and so the blood is forced up through the semilunar valves. Okay, but then on the picture on the left, when the ventricles are in diastole, when they're filling, and when blood is moving into them from the atria, because the pressure has backed up in the ventricles, they're not contracting. That means the pressure up here and the pressure up here has lessened and the blood can backflow a little bit. And so that's going to cause the semilunar valves to close. Okay, so that's during the second sound when the ventricles are relaxing. So if you think of my hands and they're going to squeeze together during ventricular contraction, move apart during ventricular relaxation. So it's lift up, lift up, lift up, lift up, like that. Okay? All right. Oh, and then a heart murmur, I mentioned that the other day. A heart murmur is just when a valve doesn't close properly. And so blood will back up into the wrong area. And that, like, it'll trickle back into the atria if it's the bicuspid valve. And you can actually hear that sound with the stethoscope, and it's called a murmur. Sometimes there's a split heart sound. So it might be, instead of like lip dub, it's la-da-dub, la-da-dub, la-da-dub. And what's going on is like the semilunar or the AV valves don't close simultaneously. And so you'll hear three little sounds. Okay, so this explains that. Let me make sure that this is on. Yes, what's your question? A split heart, she asked, is a split heart sound normal? Does it happen every now and then to everybody? I have no idea. But it's not a normal. I mean, it's not. I think it's something that might cause some concern. Just like a murmur causes concern. Do you know the answer to that? A split heart sound with any of your training? Okay.
Ventricular contraction causes the atrioventricular valves to close, which signals the beginning of ventricular systole. The semilunar valves were closed during the previous diastole and remain closed during this period. Continued ventricular contraction increases pressure in the ventricles above the pressure in the aorta and pulmonary trunk, causing the semilunar valves to open. When the ventricles relax and their pressures drop, blood flowing back toward the relaxed ventricles causes the semilunar valves to close, which is the beginning of ventricular diastole. Note that the atrioventricular valves remain closed. When the pressure in the ventricles becomes lower than the pressure in the atrioventricular valves open and blood flows into the relaxed ventricles. This accounts for most of the ventricular filling. The atria then contract and complete the ventricular filling.
Okay. So when somebody is listening to heart sounds, you notice that they put the stethoscope in various places on the chest. Do you remember when we did chapter 12 and we talked about referred pain? This is, in my mind, I call this referred sound. There are some places on the body wall where the sound of each individual valve can be heard more clearly. And so you can see those placements here on this picture. You don't have to know these for the test, but what they're doing is listening for each valve individually, like to detect a heart murmur. They could do that. Okay. Now, so we've talked a lot about the parts of the heart and that cardiac cycle, what goes on, but now we're going to look at the action of the individual muscle cells. Do you remember? I know you do, that cardiac muscle is one of the three kinds of muscle tissue. We spent a lot of time in A&P1 looking at skeletal muscle, and then we just kind of briefly talked about cardiac and smooth muscle. We're going to look a little bit more at cardiac muscle tissue here, but possibly you recall that cardiac muscle cells are cylindrical, they're striated, but they're branched. Do y'all remember that? That they're branched cells? And if you look at this slide, do you remember the connection between adjacent cells are called intercalated disc? Remember that? If I was going to draw the details of an intercalated disc, and let's say here's the end of one cardiac muscle cell, and there's its other striations, and then here's the end of its adjacent cell, there's little gap junctions that connect these. Y'all recall that? Okay. And so if you think way back in time to skeletal muscle, do you remember, let's say if you had a skeletal muscle fiber, here's its striations, and there was let's say here's a neuromuscular junction. Remember, neurotransmitters are released, and then that caused an impulse to go on the muscle cell and down the T-tubule. Recall all of that? Okay. Same thing happens on these cardiac cells. So let's say if here is signals, here's a signal from the nervous system. There's a junction right here. All right, so the impulse goes on this cell membrane, but because of the gap junctions, it can continue on the next one without this second one having its own neuromuscular junction. Does that make sense? It's because of the gap junctions in between these cells, so they intercommunicate. And so if this one is stimulated to contract, the one next to it contracts, and because it has gap junctions with the next one, it contracts, and so on. And so you have a group of interconnected cardiac muscle cells all in the wall of the atria, and then you have another group of interconnected cardiac muscle cells in the walls of the ventricles. And each of those interconnected groups, it has a terrible little name, it's called a functional syncytium. Okay? And you have one across the walls of the atria, one across the walls of the ventricles, which is beautiful because if one atrial cell contracts, they all do, which is very efficient to push that blood down into the ventricles. And when one ventricular cell is stimulated to contract, they all do to force that blood out of the heart. If you didn't have the functional syncytia, then the heart wouldn't be able to pump blood efficiently. Remember, in skeletal muscle, each individual muscle cell had to have a neuromuscular junction, at least one. Cardiac muscle is not that way. You don't have to have that many neuromuscular junctions to the heart. Okay. Another feature of cardiac cells is that once one of them contracts, the fact that it contracted acts as a stimulus for a next contraction, which acts as a stimulus for a next one, for a next one, for a next one. So they're self-exciting, and they contract rhythmically. You know that. Your heart beats with the rhythm, doesn't it? Okay. All right, so cardiac muscle cells are real special because they intercommunicate, they're self-exciting, they're rhythmic, okay? But they do have to get an initial stimulus from the nervous system. And so now what we're going to look at are the groups of cardiac cells that provide the stimulus. Okay, now that's kind of weird. We usually think of nervous cells sending impulses, don't we? But there are some cardiac muscle cells that are designed to especially send impulses. And they are the ones that we're fixing to talk about. They're of the cardiac conducting system. And let's look at this picture. What you're seeing in black on this picture, and this one may not be in your book. This is from an older book, but I like it a lot because it just simplifies everything. What you see in black are examples of fibers of the cardiac conducting system. They are cardiac muscle fibers, but they're designed to efficiently transmit impulses. Okay? And if an impulse gets on one of those, let's say if there's an impulse here, because it's connected by gap junctions to all the other cardiac cells, it's going to cause them to contract. Okay? So the impulses are flowing in just some areas on the heart. Okay? There's a very special area of a mass of these conducting cells in the upper right wall of the right atrium, and it's called the sinoatrial node, sinoatrial node. And those are cells, those are some of the few cells in the heart that actually receive a stimulus from the central nervous system. Okay? And so let's say if an impulse from the nervous system gets here, that's going to trigger an impulse along these cardiac cells that are across the walls of the atrial syncytium, or the atria, and that's going to trigger atrial contraction. Okay? And so the nervous system is just sending the impulse right here, but because of the cardiac conducting cells, it's spread across the heart. And then it's interesting that these cells get real narrow right here. And so the impulse slows down as it connects to the cells in this area. Remember, impulses travel more quickly on a thick neuron than on a thin neuron fiber. Same thing's true here. Because these cells are thin, the impulse slows down when it gets to those cells. And that's very efficient because that gives time for the atria to completely contract to get the remaining of that blood down into the ventricles. Okay, and so then that impulse is in this nodal area called the atrioventricular node. And it's also in the right atrium, but it's close to that interatrial septum at the bottom. This is the interatrial septum. All right, and so then the impulse goes from there down the first part of the septum, interventricular septum, and the fibers here are very large. So how is that impulse going to go faster or more slowly? Faster. So it shoots down this, and that's called the AV bundle, or another name you'll see in your notes is the bundle of capital HIS, His, bundle of His. All right, so it shoots down real fast, and then it splits and goes up through the walls of the ventricles, and these are called the Purkinje fibers. Purkinje. Okay, Purkinje fibers. And where you see it right there. But anyway, because the impulse now is going zoop like that, that's very efficient for ventricular contraction. If you did not have these impulses flowing through the cardiac conducting system, your heart would not contract. Okay? But every time that SA node fires, that initiates one of those cardiac cycles that we just talked about. You know, the blood flowing through the atria, down to the ventricles, and then out of the ventricles. Okay? So, did you catch what I said? Every time that fires, that triggers basically a heartbeat. So how many times it fires in a minute determines your heart rate. And this is the pacemaker of your heart. You hear about a pacemaker in the heart? For most people, the SA node acts as the pacemaker. Every time it fires, initiates a cardiac cycle. And however many cardiac cycles you have in a minute is your heart rate. Okay? Remember I said these cells are self-exciting. So once it fires, it's going to continue to fire rhythmically, without any input from the central nervous system. Okay? But you tend to have some continual input to slow down the rate of the firing or to speed up the rate of the firing. Sometimes that's not very efficient in a person, so they have to have an artificial pacemaker put in, which is an apparatus they'll put up under the chest wall, and it sends an electrical current to these areas on the heart to force them to fire rhythmically. Okay? For some people, the AV node acts as the pacemaker, but for most people and for your test, the SA node is the normal pacemaker of the heart. Okay? Imagine if someone had a thrombus form and then it dislodged from the blood vessel it formed in and landed in one of the coronary arteries that directly supplied this, or even down in here. Do you see how it would stop the impulse because these cells wouldn't have what they needed? And that person could have a heart attack just right there without prior symptoms. And sometimes that happens. That's scary, isn't it? But sometimes you hear about a person dying of a heart attack. You know, they may have been to the doctor last week and had full, good heart at that point. Yeah. So, cardiac conducting system is a big deal with the action of the heart. All right, and so this lists all the different parts of it. It starts. You need to know the order. It starts with the SA node. This is the normal order. The SA node, and that means then it goes across the walls of the atria through these. The junctional fibers are the ones that go through the atria. You don't have to know that name, but from the SA node, and then the impulse travels across the atria, and then from there it gets into the AV node, which then goes down into the AV bundle, and which branches. You don't have to name the branches, but they branch, and then that goes to the Purkinje fibers. So make sure you know that order, okay? SA node to AV node to bundle of His to Purkinje fibers, okay? All right. So here's your book's version. Here's the SA node. It goes across the walls of the atria, so they contract simultaneously, and then it gets to the AV node, down the bundle of His, where it splits up into the Purkinje fibers. Okay. And the pictures on the right, don't worry about for your test, but it's real interesting that the arrangement of the cardiac muscle fibers in the ventricle, see how it's that whorled arrangement? And so when the heart contracts, it almost twists a little bit as it contracts. But that helps to get that blood efficiently out of the heart. Okay.
Action potentials originate in the sinoatrial node and travel across the wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
Okay, so a lot of people have heard of an EKG or ECG. It stands for electrocardiogram. Someone told me way back, one of my students, because we'd always say EKG, but cardio, starts with a C. I said, well, the reason they say EKG in the medical setting is because if you're calling for an emergency situation, ECG, that might be confused with EEG, which is electroencephalogram, which is brain activity. But the real reason it's sometimes EKG is the true British English version of this word. The cardio has a K in it instead of the C. I think that's the real reason. But anyway, you can say it either way. I always say EKG. But what that is simply a recording of the electrical changes during through that cardiac conducting system. Electrical changes because it's like an impulse. It is an impulse. Remember, in an impulse, sodium moves in, that changes the voltage from -70 to higher, and then potassium moves out and the voltage goes back down. That's called depolarization, repolarization. Remember that? Okay. And an EKG is a measurement of that activity across the walls of the atria and ventricles. All right. Many of you one day will have whole units in your future courses on reading an EKG. I'm not good at it. Okay. But I want you to stay right here and look at this. I want us to be able to identify some different parts. Okay. And so if we look at an EKG, here you see it. This is the electrocardiogram. The instrument used to record that is called an electrocardiograph. The graph is the instrument, the gram is the recording, which makes no sense to me because The recording looks like it's on graph paper, but the recording is the gram. The graph is the instrument used to measure it. But you know that if you had an EKG run, they're going to put these, what do they call them? Electrodes, but they don't send an impulse to you, but they detect electrical activity in the heart. They put those across the wall of the chest, or they could put them on your wrist and your ankles. Sometimes they do it that way. But what that recording is doing, it's the instrument is measuring electrical changes from one of those electrodes to the next, and and that's an indication of electrical activity going on in the heart. Okay, and so if you look at this strip, that is a heartbeat or a cardiac cycle. There's a cardiac cycle. There's one, there's one, there's one. And so if you looked at one of those, like you see here on the bottom, you can see it's measured in millivolts and milliseconds, all right, on this little graph. And each little square in the graph represents a certain voltage or a certain period of time. Okay, and they're looking at that and they're measuring that to see how strong the heart is and to see how long it takes from, say, an atrial contraction to a ventricular contraction. They're doing a lot of that measurement, which you will do probably one day in a future class. In this class, I want you to know what each of these deflections represents. Okay, so here you've got various waves. There's a P wave, here's a Q wave, there's an R wave, and an S wave, and then a T wave. Okay, and the Q and the R and the S we call all the same thing, a QRS complex. Okay, and so on the slide before this one, it tells you what they represent. Okay, and so if you look at that, the P wave represents the electrical changes that are occurring, the depolarization that occurs across the atria when the impulse goes from the SA node to the AV node. Doesn't that trigger atrial contraction? Okay, so the P wave represents depolarization of the atria. Okay, the QRS, and it is immediately followed by atrial contraction, and so this gives you an idea of how strong the atrial contraction is by how high the deflection is. Okay, and then the QRS complex represents the depolarization, that means sodium moving in, the depolarization from the AV node down the bundle of His branches and up through the Purkinje fibers, which initiates what contraction? The impulse moving in the ventricles initiates ventricular contraction. So this is depolarization of the ventricles. And look at the deflection. It's much bigger than the P wave, isn't it? The QRS is much bigger than the P. Aren't the ventricles a lot stronger than the atria? So it's an indication that the ventricular contraction is much stronger. And then the T wave represents the electrical changes during repolarization in the ventricles. Okay? So what's missing in this picture? If you have depolarization of the atria, depolarization of the ventricles, and repolarization of the ventricles, what's missing? Repolarization of the atria. It occurs, but it occurs at the time that the ventricles are depolarizing. And that deflection overrides the deflection on the recording. I'm just making a wild guess. I have no idea. But I would think that, there possibly somewhere out there is a person that actually has a way, it shows a wave for ventricular repolarization, but atrial repolarization. But if it showed it, that's probably an indication something's really messed up in his heart. If you had the four, but they should be. It would have to be real close together. But anyway, they measure this. You can also look at how long a period of time between this and this, and then between this and this, and this and this, and you could figure out the heartbeat based on that. Or you could take a whole minute's worth of the graph and just add up your cardiac cycles and figure out the heartbeat. You can look at one of these and pretty quickly tell if the heartbeat is regular or irregular. If the QRS is that R wave if they're not all pretty the same length apart. You know, I could tell that. But that's about all I could tell on it. Okay. All right, and so this picture, these are showing you what is actually going on in each of the chambers during each little stage. You don't have to know that for the test, but it's interesting to look at that and to see. But, all right, now, all right, so we've talked about movement of blood through the heart. We've talked about the supply of blood to the heart on the outside. We've looked at the nervous, the impulse activity through the heart that initiates all that blood flow or the movement of the blood. But now we're going to look at what conditions in the body cause the SA node to fire. Are your notes not right? Y'all are flipping pages. Oh, I stapled them. I stapled one backwards. I'm so sorry. Yeah. So this is page 16. Okay. Sorry. All right. Okay. We've already learned in past A&P that sympathetic impulses increase heart rate and strength of contraction. Parasympathetic impulses do the opposite. Now we're going to go a little step further. Sympathetic impulses go into the heart, get there by way of nerves called accelerator nerves. Okay? And the accelerator nerves have junctions at SA and the AV nodes. Okay? For some people, the AV node is the pacemaker. You know, every time it fires, that triggers ventricular contraction, doesn't it? But anyway, the neurotransmitter released by accelerator nerves is norepinephrine. Remember, norepinephrine in the endocrine system acted as a hormone from the adrenal medulla, and its effect on target cells was like sympathetic activity. Okay, well, here it's acting as a neurotransmitter, and it does that same thing. It increases the heart rate and force of contraction. The parasympathetic impulses getting to the heart get there by way of one of the cranial nerves, the largest cranial nerve 10, called the vagus nerve, and it releases acetylcholine. So if a parasympathetic impulse gets to the SA node, that's going to slow down the firing, the presence of acetylcholine there. The presence of norepinephrine is going to speed up the firing. All right. Well, there are body conditions that cause your brain to send either a sympathetic or a parasympathetic impulse. And that's what we're going to look at now. You have a place in your brain stem called the cardiac center. It's one of your vital control centers. The cardiac center. It's in the brainstem, specifically in the medulla, and there's two parts to it. There's a cardio accelerator center, and that one is going to initiate a sympathetic impulse. That makes sense. And then there's a cardio inhibitor part of it that will initiate a parasympathetic impulse. That makes sense, doesn't it? Okay. So various body conditions will activate either the inhibitor center or will activate the accelerator center. And that's what this is talking about. Okay, and the first thing we're going to look at is looking at some receptors that are in the walls of some of your blood vessels that are sensitive to the pressure of the blood in that blood vessel. So they're called presoreceptors. They're a type of baroreceptor in the body, and they're sensitive to changes in blood pressure. Okay, the first ones we're going to look at are in the walls of the vena cava, the superior and inferior vena cava. All right, so I want you to stay on this page, and let's look at a picture. And it, let's say here's this picture is not showing the receptors that I'm fixing to talk about. I'm just going to draw them in. But let's say here's a presoreceptor in the superior vena cava. There's one in the inferior vena cava. And they are sensitive to elevations of blood pressure. Okay. Now, this is common sense if you think about it. If the blood pressure is high here, does it make sense to you that to alleviate that pressure, that blood needs to get flowing through the heart? Because blood can't back up in a vein. Blood only goes in one direction. We'll see why later on today, why it can't back up. It only can go in one direction. So the only way to alleviate the pressure right here is to get it moving through the heart. So if the venous pressure is high, you need the heart rate to increase to move that blood on through. Does that make sense? Okay, so these presoreceptors in the vena cava are going to activate, they're going to send impulses to the cardio inhibitor center, which, like, here's the cardiac center, one's the accelerator, one's the inhibitor, but it's going to go to the inhibitor center, which is in turn going to send an impulse along the vagus nerve, which is not shown on here, but the vagus nerve would come out of the brain and speed up the heart rate. I said that exactly wrong, didn't I? Yes, I did. It's going to activate, the accelerator center, because you want it to move through. It's going to activate the accelerator center, which in turn is going to go down, and that would be the accelerator nerve. So it's part of the sympathetic division of the nervous system. Okay, does that make sense? All right, you have other presoreceptors that are in the walls of some of the blood vessels that the blood flows into once it leaves the aorta, and some of those are in the aorta itself, and then also up in the carotid arteries. These swollen areas, they're called sinuses, but that's where the presoreceptors are. If the arterial pressure is high right here, do you understand that if the heart rate increased, that would put even more blood there, which would up the pressure even more? So if the arterial blood pressure is high, you want to slow down heart action, okay, to give time for this blood to move on through the systemic circuit. Okay, and so the presoreceptors in the aorta and in the carotid arteries are going to send impulses to the cardio inhibitor center, which in turn sends an impulse along the vagus nerve to slow down the heart rate. Okay? I spent way too long on that. But it can be tricky. But think about the blood in those blood vessels. Would it benefit if you wanted to relieve the blood pressure to speed up or slow down the heart? And then if you think through it, it's not that hard. Unless you're standing in front of a class trying to explain it all, and everybody in there is probably already understanding it. Sorry. Okay. Some other things that affect the cardiac center are body temperature. If your body temperature increases, that's going to activate the cardio accelerator center, so your heart rate will increase. If your body temperature drops, that will slow the rate. Okay. Some other things are various ions in your blood. Elevated potassium, you may just need to memorize this. Elevated potassium slows the rate. If you want to look at exactly why, you remember on a nerve impulse, which we're going to call it a muscle impulse now through the cardiac conducting system. You remember how sodium's on the outside, potassium's on the inside? If blood potassium, that's extracellular fluid, that means you have some extra potassium out here. So there's not as big a difference on the two sides. And that means potassium is going to move out more slowly because it's not as big a difference. And that will slow the rate. Elevated calcium. Calcium is needed for muscle contraction. The more calcium you have, the more it can contract more quickly. Okay, so that's going to speed up muscle contraction or the rate of the heart. Okay. All right, now this clinical application I'm not going to test you on, but you do hear a lot of this terminology in a medical setting. If somebody has bradycardia, that's a abnormally slow heart rate. Tachycardia is the opposite of that, a continually fast heart rate. Sometimes the heart flutters, and that means it's super fast contractions. And hopefully that doesn't last very long because it's not real efficient if it's doing that. Premature beat, it throws off the cardiac cycle. And then I've talked about the pacemaker. If you have an artificial pacemaker, um, what that is. Some people I mentioned to you have the AV node as their pacemaker, and so that's what this ectopic is. It's not the normal one. You won't be tested on these terms, okay? But you see those in a medical setting. You may have family members who've suffered from some of that. And fibrillation, I didn't go over that one. That's when you have certain areas within the heart wall that are not contracting efficiently, so they're not working as that functional syncytium should work. And so that causes the movement of the blood to not be complete as it goes from one chamber to another or goes from the ventricles out of the heart. And that can be very life-threatening. There's atrial fibrillation, and there's ventricular fibrillation is the really dangerous one, because that's the one that's got to get the blood out of the heart. Okay. So we've done everything with the heart. All right, now we're going to look at the blood vessels. And like I mentioned to you the other time, we're not going to name specific blood vessels other than those right there at the heart. In lab, you're going to be naming a lot of blood vessels. But some of the blood vessels you name are the arteries, and some of them you name are the veins. And so we're going to look at the different categories of blood vessels in this section. And there are arteries and arterioles and capillaries and venules and veins. I've already kind of gone over that. Okay, and so I want you to stay on the slides that it has descriptions of each. But if you look, remember, when the blood leaves the heart, it's in an artery, and then it moves into, as the artery branches into smaller and smaller arteries, to the arterioles, which branch into smaller and smaller ones till you get to the tiniest blood vessels. And then from there it goes through the venules. Then they pool together into veins that go to the heart. Okay, so you know that order. Think about it. If let's compare all that blood vessel circuit, the length of it, to a garden hose, and think of the faucet end of the hose. That would be the proximal end, and then the distal end where the water comes out of the hose. All right, where's the water pressure the highest? At the faucet or at the distal end of the hose? At the faucet. And the farther the water moves, the more pressure it loses, right? Okay. Same thing as with your blood. When the blood leaves the heart, it has its highest pressure it will ever have. And then as it moves from the arteries into smaller arteries, the pressure drops, and then drops and keeps dropping and keeps dropping. Okay, and because of the pressure differences of the blood in each of these different blood vessels, that is significant as far as the structure of the wall of the blood vessel is concerned. On the left, you see an artery, and then in the picture on the right here, you see a vein. And do you notice how the muscle in the wall of the artery is much thicker than the muscle in the wall of the vein? I mean, overall, their diameters might be the same, or most of the time, veins are actually bigger in diameter than arteries are, but always the artery is more thick-walled because it has blood of the highest pressure. And so it's got to be thick and strong so that it won't burst. Okay? An aneurysm is when an artery loses some of its strength and it bulges and it bursts, which is terrible. All right, arteries also have a lot of elastic tissue, so there would be elastic fibers in here. When you were looking at elastic connective tissue in A&P1, you were looking at a section of an aorta, and so you saw those elastic fibers. The aorta is the thickest walled of all the arteries because that's the one that has the most pressure, isn't it? The one most closely associated with the left ventricle. Okay. The layers in the walls of the blood vessels, your book talks about them. The internal layer is you can call it the endothelium or the tunica interna. I won't use those terms. And then the tunica media is the muscle and elastic layer, and tunica external is just the fibrous layer on the outside. But if you look at the tunica interna, or sometimes it's tunica intima, but it is nothing but simple squamous epithelium. Okay, all of your blood vessels are lined with simple squamous. Okay, it's just the other parts of it change as you move on through. If you look at the vein, it has muscle in its wall, and there's some elastic fibers, but nothing like you see in arteries. But what you notice that's really significant about the vein is that right there. Some of the endothelium, which is the little squamous cells, is arranged in valve-like structures. It looks like little teeny semilunar valves, basically, but it's made of squamous epithelium, not fibrous tissue like in the heart. So if the blood flows this way, it can easily get in between that, but if it tries to back up, they're going to close up. So it acts sort of like that semilunar. And so do you see, this is the reason that blood cannot back up in veins, just because of the valves. The veins are the only ones of the blood vessels that actually have valves. Okay? Arteries don't have that. Okay, so here you see some micrographs, and you can see here's an artery and here's a vein. You know, at first glance you think, oh, that vein is bigger. But if you look at it, because it's somewhat collapsed, it's obvious it's not as strong as that one. The arteries stay big and open. You know, veins might collapse a little bit. The blood doesn't have as much pressure in a vein as it does an artery. Okay, and then this outlines. You don't have to know the 3 layers. Don't worry about that. But the other picture was an older version of this, which is in your book. I promise you, I'm not going to ask. Of course, I could. That's super easy. But the muscle is smooth muscle, by the way. All right, and then here you see another view of the elastic fibers in the artery. And this would be, do you see the simple squamous right there? Okay. All right, now this is showing you a little arteriole. This is like one of the tiniest arterioles. Do you see how it almost is nothing but the simple squamous? It's lost most of the muscle. You have little bits of muscle fibers going around it. Okay. And so some of the arterioles have more muscle than that. But this is one that's connected directly to the tiniest of the blood vessels, which is the capillary. And see how the capillary wall is nothing but simple squamous? And because it's simple squamous, things can move in and out of it very easily. So that's where the exchange takes place. The speed of the blood flow have slowed down a lot by the time it gets to a capillary. In an artery, let's think about the aorta. Does it make sense to you that the blood in the aorta and the bigger arteries would go fast, slow, fast, slow, fast, slow, fast, slow? Every time the ventricles contract, that pushes the blood, it moves faster. When the ventricles relax, it slows it down a little bit. And then with the next contraction, it's pushed more. So it goes fast, slow, fast, slow, fast, slow. But that kind of evens out by the time it gets to the small arterioles. And then when it gets into the capillaries, it's moving pretty slow, which is perfect. Because if it moved fast, it had a lot of pressure in it, it would blow out that capillary. And if it moved too fast, there wouldn't be time for the nutrient and gas exchange. Okay? There is see that right there? There's an encircling muscle fiber at the base of each capillary where it joins to an arteriole, and that controls how much blood is going to flow into that capillary. It's called the precapillary sphincter. Sometimes they're more constricted than other times. It just depends on the need of the tissue that's fed by that capillary network, if it needs more blood or less blood. Okay. Capillaries are that's where all this exchange takes place. I've talked about that. And here it talks about the precapillary sphincters. So on this little picture, this is a real simplified view of all the blood vessels. Here's an artery that branches into arterioles, and then there's a little capillary bed. And you see the color change? That represents the fact that there's gas exchange between oxygen and CO2. So obviously this would be of the systemic circuit, not the pulmonary circuit. The colors would be opposite in a pulmonary circuit, wouldn't it? Okay, and so gas exchange takes place, and then it gets into a little venule, which leads to the veins. Okay, every now and then, well, you have a shunt that allows some of the blood to bypass a capillary bed. Don't worry about that for the test, but that just the blood would flow there if all these sphincters were pretty much constricted in that area, didn't need much blood at that moment. Okay. Okay, so this is showing you that capillary walls are very permeable. Some substances actually move in between the cells and not just through the cells. Okay. Now, when exchange takes place at the capillary level, it does so through diffusion. That's just simple old diffusion. Lipid-soluble substances that are small enough can go from high concentration to low. Filtration is due to hydrostatic pressure. If there's more water pressure in the blood vessel, in the capillary, than in the fluid around the blood vessel, around your cells, then substances will move out, dissolved in that water. Okay, and then osmosis. The water movement is also determined by osmotic pressure. Remember, osmotic pressure is due to the presence of the solutes. Okay, the more solutes, the more the water will stay there. Okay, osmotic pressure and hydrostatic pressure, or I guess I should do it like that. Osmotic and hydrostatic pressure oppose each other. If here's a blood vessel like a capillary, you have osmotic pressure and you have hydrostatic pressure. If the osmotic pressure is higher, water's going to stay. If the hydrostatic pressure is higher, water's going to leave. You see that? Does that make sense? Because hydrostatic pressure is a pushing pressure for water. Osmotic pressure is a pulling pressure for water. Okay? And that's easy if that's the only place you had hydrostatic and osmotic pressure. But you also have osmotic pressure and hydrostatic pressure in the spaces surrounding the blood vessels because you got fluid there, because that's where your cells are going to be, so that extracellular fluid. So it's the combination of all of that and the whole sum that determines if substances are going to move in and out of that blood, if the water's going to move. Okay? And so that's what this is showing you. So let's look at this. Here's the arterial end of blood in the systemic circuit, and then on the right would be the venous end, and then in the middle you're seeing this capillary, and then here's your tissue cells, and this fluid bathes the cells. All right, what we're going to be doing is the substances are going to move either from the blood into that fluid, the intercellular fluid, or substances are going to move from the fluid into the blood plasma. And that movement of the water, this is all water movement, but things are dissolved in water like oxygen. All right, that movement then is determined by these opposing pressures. Okay, so if you look at the incoming blood, do you see where it says the outward force of hydrostatic pressure is 35 millimeters of mercury? Millimeters of mercury is a unit of pressure. Okay, and then so that means the hydrostatic pressure is pretty big compared to the osmotic pressure. See how it's 24? And this arrow representing this doesn't mean things are moving in. That just means that's the pulling pressure on water. Do you see how the pushing is bigger than the pulling? Okay, and so that means the net outward pressure is positive. Okay, and so that means water's going to move out of the blood, carrying with it things that are going to be then moving into the cells. Okay, but as it loses its water, look at the hydrostatic pressure. See how it drops from 35 to 16? Okay, and the osmotic pressures, they stay pretty much the same because your proteins aren't moving, so that kind of maintains that osmotic pressure. But because it's lost water, It's lost hydrostatic pressure, and now the osmotic pressure overrides the hydrostatic pressure. And so substances are actually going to flow in from the tissues, bringing with it things from your cells, like CO2, like urea, things that the cells make. Does that make sense? Okay. You will not have to put numbers to this on the test. Okay. But you will, you probably already know what I would ask you, the answers to what I would ask you, in that at the capillary level, fluid moves out of the blood at the arterial end, and then fluid moves into the blood at the venous end of the capillary bed. Does that make sense? Okay. But it's because of these changes in pressure. Okay. All right. And so just know, that the hydrostatic pressure is bigger than the osmotic at the arterial end. Osmotic is bigger than hydrostatic at the venous end. So that'll draw water back in. Okay. And you do have pressures in the interstitial fluid, and these numbers that you see take that into account. It doesn't really show that to you on this picture, but it takes that into account. Okay. Now, on this video, he's going to be talking about filtration pressure, net filtration pressure, and he'll say hydrostatic and osmotic. What net filtration pressure is, like here, the net outward pressure, remember I said it was positive? Okay, an 11. And that is the filtration pressure. If it's positive, that means substances will move out. If it's negative, substances will move in. But they didn't really lay that out on the right side here. What they did is, instead of having a net outward pressure being negative, they described it as a net inward pressure being positive. But if I did it, I hope I'm not confusing you. If I made that a net outward pressure to say what is the filtration pressure, you would say 16 minus 24, because over here we did 35 minus 24 was 11. 16 minus 24 is a negative 8, isn't it? So now the filtration pressure is negative. And so that means it's not going to filter, move out. Instead, it's going to come in. Okay.
At the arterial end of the capillary, the net filtration pressure is equal to the net hydrostatic pressure minus the net osmotic pressure. The net filtration pressure is 13 millimeters of mercury. This causes fluid to move from the capillary into the interstitial fluid. At the venous end of the capillary, the net filtration pressure is equal to the net hydrostatic pressure minus the net osmotic pressure. The net filtration pressure is minus 7 millimeters of mercury.
I want to pause just a minute. Notice that on this video, he's saying net hydrostatic pressure. That means it's taking into account hydrostatic pressure on both sides. Okay. So.
This causes fluid to move from the interstitial fluid into the capillary. Approximately 9/10 of the fluid that leaves the capillary at its arterial end re-enters the capillary at the venous end. About 1/10 of the fluid passes into the lymphatic capillaries and returns to the bloodstream via the lymphatic system.
And we'll see that in the next unit, okay, that lymphatic flow. All right. So we've talked about arteries, we've talked about capillaries, a little bit about arterioles. Now we're going to look at venules and veins, especially the veins. Like I've already mentioned, they're thinner walled than the arteries because they carry blood with lower pressure. And they have these valves that prevent a backflow. They don't cause movement of the blood, they just prevent it from backflowing. If somebody's valves in their veins don't work, that can be very dangerous because the blood is not going to efficiently make its way back to the heart. Sometimes you see varicose veins. That's when some valves are not working properly and they really get bulging. It's not just a cosmetic issue, it's a medical issue. Okay. This graph is interesting. It's just showing you that at any given moment, most of the blood inside of you is actually in some veins. Remember, some of those veins were real big in diameter. Um, you don't have to know any of these percentages, but and then the little table on the right, just further describes, it's a repeat of what we've already done. Okay. Okay, now we're going to look at what causes the blood to flow in these blood vessels. The whole reason blood flows in an artery is just because it's got a lot of pressure in it. Just like the whole reason water moves through a garden hose is because of the water pressure. Okay, the water pressure, the hydrostatic pressure, which is the blood pressure, is high in an artery, and therefore blood moves through because it's just left the heart. But when it gets to the veins, it has slowed down to, the pressure is just kind of bottomed out by the time it gets to the veins. So you might wonder, well, how does it get back to the heart? Many times against gravity. How does it get back up there if it's coming from the lower part of the body? Well, most of your veins are pretty close to some skeletal muscles. And when a skeletal muscle contracts, it gets thicker, and that squishes on the neighboring vein. And if a vein is squished, because it's thin walled, that's going to push the blood inside. And because there are valves in that vein, the blood can only go in one direction. So the main two things that keep the blood going in that one direction, the contraction of the muscles, and then the valves don't cause it to move, it just prevents a backflow. Okay? But veins do have smooth muscle in their walls. It's just not as much as arteries, so they are capable of constricting. And then in the veins that are in your ventral cavity, pressures associated with breathing. I know that doesn't make sense to you right now. We haven't done the respiratory system, but there are pressures associated with the inhaling and exhaling that help the blood to flow through the ventral cavity in those blood vessels in the veins. Okay. Have you ever noticed if your arm hangs down from a table, or you crossed your legs for a long period of time, or you're sitting where there's a lot of pressure on your leg for a long period of time, your leg or your arm falls asleep? All right, what's going on is you're not contracting surrounding muscles, and the blood is kind of stopping in your veins, which puts a lot of pressure. That means more can't move in from the capillaries, and that's going to put pressure on the capillaries, and then you will have fluid buildup in the tissues. I mean, it's a cascade of events, but it triggers nervous system receptors that cause you to have that feeling. So how do you alleviate it? You move, don't you? Which is contracting your muscles and getting the blood to flow. Okay. Some of you might be working with paralyzed patients in the future, and you might initially wonder, why do I need to move the limbs of this person who will never walk? And it's to get the blood flowing, to keep the blood flowing. Okay? Because that muscle contraction, that thickening of the muscle, really aids in the movement of the blood. Okay. All right, so now we're going to look at blood pressure. Blood pressure is measured in the unit called millimeters of mercury. That's a unit of pressure. I want to explain where they come up with that, because that's confusing sometimes. It's kind of a strange unit. But what is the name of an instrument that measures air pressure? A barometer. Okay, here's a real simple barometer. It's a little dish filled with a metal that is liquid at room temperature. Can you think of a silver metal that is liquid at room temperature? Mercury, like in those thermometers. Mercury. Hg is mercury. All right, so here's a little dish of mercury, and then I'm going to put an upside down, real skinny little tube that's open on one end. Upside down in that. And it's measured in millimeters. Okay. If you set, this is our little simple barometer. if you set this at sea level, air pressure at sea level is enough to push that mercury up this column to a height of 760 millimeters. Therefore, air pressure at sea level is 760 millimeters of mercury. If you put any other liquid in that dish, it wouldn't move to the same height. So that's why you cannot say pressure is in millimeters. It's millimeters of mercury, okay? Which 760 millimeters of mercury is 1 atmosphere. That's equal to 1 atmosphere of pressure. The reason I put just millimeters of there is because I'm measuring the height of that tube. Okay. All right. So that's where the start over. Okay. So that's where millimeters of mercury comes from. Now let's see how that works with your blood pressure. You know, when you have your blood pressure taken, it's like 120 over 80. The 120 and the 80 are millimeters of mercury. That's the pressure that's being measured, that amount of pressure, which is not as much as 760 millimeters of mercury. It's not as big as air pressure, but it's still pressure. All right, pressure changes in various blood vessels. Usually when we measure blood pressure, we're measuring arterial blood pressure of a blood vessel pretty close to the heart, like the brachial artery in the upper arm. That's pretty close to the aorta. And that's a real good indication of heart effects on the movement of the blood. All right, the top number, like if we did 120 over 80, the top number is the systolic reading, and that's the pressure of the blood in that blood vessel when the ventricles are contracting. The pressure's high. When the ventricles relax, the pressure is not as high. And so that's the low number, which represents the pressure during ventricular diastole, which is relaxation and filling. Does that make sense? Okay. And so when I told you a minute ago that blood in an artery goes fast, slow, fast, slow, fast, slow, it's going fast when it's got the high pressure during contraction, and slower when it's going slower, that means the pressure is lightened up. Or because the pressure is lightened up, it moves more slowly, I should say that. Okay? All right. The average norm blood pressure reading is 120 over 80. Okay? You want it to be about 40 millimeters of mercury difference between the two. You need a good difference, because let's say it's 120. I need a picture of the heart. Oh, the instrument used to measure blood pressure, if you didn't know the name, we always say blood pressure instrument, but it's a sphygmomanometer. Sphygmomanometer is how you say that. And there it is. We'll use one in lab next week. You'll get to learn how to use it. I need a picture of the heart. Let me pull this up. Oh, that was a good one. I could have had it. Let's see. Sphygmomanometer. Like Sphinx. Nope, that's not what I want. Yes. She said, if we say blood pressure cuff on the test, is that wrong? Okay. Let's say somebody's blood pressure is 120 over 100. Okay. First glance, it doesn't seem so bad. It's kind of close to 120 over 80, isn't it? All right, but it's 120 over 100. So let's say if it's 100, because the brachial artery is pretty close to this, so that means it's about 100 there. All right. So do you see how if it's 100 when the ventricle is relaxing, then the ventricle has to work harder to force the next round of blood up in there because the pressure's already high. it's going to wear out the heart. High blood pressure over time can destroy the heart. It's called the silent killer. You ever heard of that? Okay. If your blood pressure is too high, if the diastolic reading is consistently too high, the ventricle just has to work harder than it should. Okay? If the systolic pressure is continually really high, that's going to affect the blood vessels themselves, because they're made to withstand a certain amount of pressure, but not every pressure. Okay? Which can also be devastating. And it can affect your kidneys. We're going to see when we get to one of the last units and talk about the kidneys, how blood pressure and kidney action are directly related to each other. There's a big correlation in kidneys and blood pressure. And anyway, so you want to keep it close to 40, the difference being 40. Okay. If your blood pressure, a lot of young women have a much lower blood pressure than 120 or over 80, like 100 over 60. That's okay. I mean, but you don't want it real high all the time. It's okay the 100 over 60. As a young person, as you get older, that tends to be kind of low. But they're especially looking at the diastolic reading, unless your systolic is like 180, way up there. Okay. Oh, wait. We have done that. Let's go way back down to the bottom. Y'all are excited because we're getting close to the end. Okay. She asked, what does blood pressure medicine actually do? There's a lot of different kinds. Some blood pressure medicines are just diuretics, which remove some of the fluid component from the blood, which lessens the pressure. Some of them, in a cascade of chemical reactions in the blood, cause blood vessels to relax more, which lightens the blood pressure. Some are called calcium blockers. Calcium has a direct effect on heart action, which affects blood pressure. There's a lot of different kinds. But how many of you have parents who take, some of you may take high blood pressure medicine, but for everybody, how many have parents who take it? Chances are you may too one day, if you don't now. If your parents don't take it, you can thank someone. It can be genetic, but you can control it with sometimes just your lifestyle, but you also can control it medically. And as long as it's being controlled medically, that's great. If you are diagnosed with hypertension, which is high blood pressure, it is, I hate to use this word, but it is stupid not to treat it medically if you can't control it with your lifestyle, because it will make you live longer. Okay. I knew a person one time, a young man, who was on blood pressure medication, but he went a long time without taking it. And he had a heart attack. He worked here. Anyway, he had a heart attack at a very young age. I love this graph. If you look at it, this graph is showing you how your blood pressure changes as it moves away from the heart. So you start in the aorta. Do you see how blood pressure in the aorta? It goes from 120 to 80, 120 to 80, 120 to 80. So the difference is about 40. And then as it gets to your smaller arteries, do you see how the difference is less? That's because it's farther away from the heart, so the heart doesn't have as a direct an impact on the pressure of the blood way down that road. Okay? And then by the time you get to the smallest arterioles, there's no difference. Okay? And so what's going to keep it moving in the smaller arterioles is just the contraction of the little muscle in the walls to keep it flowing freely through, so it doesn't stop. Then when it gets to the capillaries, they're real thin walled, so it's really good that there's not a big pressure changes, because it couldn't accommodate for that. When you take a pulse, you're taking the pulse of your radial, most of the time your radial artery, or any artery, And you feel it dilating, constricting, don't you? And it dilates during systole, it constricts during diastole because there's less pressure in the blood, so the blood vessel squeezes to accommodate that to keep it on flowing. Okay, but by the time it gets to the venules and the veins, look, nothing. So that's where you have to have the other mechanisms kick in, like skeletal muscle contraction, the pressures from breathing. Okay. Now, your cardiac output is basically how much blood leaves the heart each minute, and it's based on the heart rate, and then also how much blood leaves with each ventricle contraction. That value is called your stroke volume. Each time the ventricles contract, how much blood leaves the heart. And then your heart rate is how many times that happens in a minute, of course. And then your cardiac output then is both of those combined. And your cardiac output determines how efficient your heart is in getting oxygen and other needed substances to your cells. So this is a measurement that they definitely use in a medical setting, is this cardiac output. All right. So we've talked about blood pressure, but we have not looked at some things that can affect your blood pressure. And that's what this slide is showing you. So I would like you to treat this slide as if I typed it up. So you need to know this for your test. Okay. Anytime you have an increase in the amount of blood, does it make sense that's going to put more pressure on the artery walls? So that will up your blood pressure. Okay. If your heart rate increases, think about this. If you have a fast heart rate, okay, so it's contracted, the ventricles have contracted, blood moves into the aorta, and then as the blood hasn't moved all the way through before it contracts again. So see that's going to up your blood pressure. So that's why a consistently elevated heart rate can be damaging. Some people's heart rates are just naturally higher than other people's. You know, it can range. You know, if you exercise a lot, your heart rate may be 50, and that's normal for you. Whereas somebody else may be 85, and that's normal for them. But if your heart rate, you know, is 100 and up, you know, that can be pretty serious, because over time that's going to affect your blood pressure. The stroke volume, obviously, the more that is leaving the heart with each contraction, the higher the blood pressure is going to be. And then blood viscosity deals with the thickness of the blood. The thicker it is, does it make sense? It's not going to flow as freely. If you have a lot of fat in your blood, it thickens it, and it won't flow as well. You have a lot. If you have a whole lot of red blood cells and not enough plasma to accommodate that, that thickens your blood. So a lot of things can affect the blood viscosity. Peripheral resistance has to do with the walls of the blood vessels. If they were not elastic, they lose their peripheral resistance, because like when you take your pulse, you feel that elasticity. You feel it dilate. If it can't dilate to accommodate the systolic pressure, just imagine if it doesn't dilate, that means that pressure is going to be even higher, right? Okay. So when your blood vessel walls lose their elasticity, the peripheral resistance increases. Also, if the blood vessel wall gets thicker, like it does with a buildup of fat in the wall of the blood vessel called atherosclerosis, which can happen with aging, that increases the peripheral resistance, which affects blood pressure. Okay. And elevated blood pressure over time wears out the heart. Okay. All right. Well, that's it. We got through a little early for this unit. But you've got your test next time on the blood and the cardiovascular system.